Welcome everybody. Today's video is focused on the benefits and opportunities within in-community services. If you have not seen our foundational videos and webinar on in-community services, those are available on the MCTAC website, and I would recommend those for you if you are not familiar with in-community services. What you can expect from today's video is an overview of in-community services from Pat Lyncourt, the benefits of in-community services, again with Pat Lyncourt, and then finally Silver Lake and Odyssey House are going to walk through their experiences implementing and utilizing in-community services. They're going to talk about some of the hurdles they overcame, their successes, and probably some recommendations for you as well. So we hope that this is a productive and successful experience. With that, I'd like to turn it over to Pat Lyncourt.
Hello, thank you for joining us. I just wanted to give a quick overview and turn it over to the providers who are actually gaining an experience with the use of these services. On October 1st of 2015, Part 822 regulations were updated to allow for in-community services. And then with the carve-in of Medicaid services to managed care, the billing for those services through Medicaid was allowable. So the rules to the billing for in-community services are that a person has to be enrolled in a Medicaid managed care plan, and they have to be enrolled in an outpatient clinic, or they have to be on the way to enrollment in an outpatient clinic. So the outpatient clinic really can provide almost all of the services available in an outpatient clinic to any person who is a patient or a potential patient. So the benefits that OASIS anticipates through the use of these services is filling gaps in the service delivery system, allowing providers to reach out either through peers or clinical staff to people who have become disengaged, bringing the resources of a clinic treatment to patient populations that cannot or will not come to the clinic or might be reluctant to engage into a clinic. So some of the places where you'll hear people talk about that in use is in housing, in outpatient clinics that are primary care focused, but there are lots of possibilities here for innovation. We think that this will expand access to care for people who might not independently seek services in an outpatient without that kind of outreach. And we think it'll also help providers strengthen linkages to community resources and become more connected to some of the other service providers by being able to reach out into the community service providers to provide something that's useful to the patients or the members that they see as well. And then we think it also will increase opportunities for integration. So one of the major pushes will be to better integrate services with physical and mental health services, and this by allowing staff to be outside of the four walls and in the community, it will allow for a number of innovative ideas that for providers to pursue. And overall, this may help to bring more people into services. There, is a statistic that frequently is cited that people who are in need of treatment, only 1 in 10 of them actually get services. So this is one of the tools that we hope will be able to help providers to reach to the other 9 people who are currently not being reached in the community. So with that, I would like to turn this over to providers who are actually innovators. They're out front in the use of these new services and hear what successes that they're having. Thank you.
Hi, good afternoon, everybody. So I'm Mary Callahan. I'm a Senior Manager and Director of Outpatient Services at Odyssey House. And I'm here with Victoria.
Victoria Porcell, I'm the Clinical Director at Silver Lake Support Services on Staten Island.
And we're here to discuss the opportunities for use of in the community services that Pat Lyncourt from OASIS just described to everybody. So, Victoria, I hear you guys at Silver Lake are right now doing in the community services, and Odyssey House, we've been doing them as well. And we wanted to discuss, I guess, some of the things that you think you've noticed, the benefits to your programming and to your clients that you guys have noticed, as well the ones that we at Odyssey House have noticed.
Yes.
So at Odyssey House, we really had to take the time to consider a way to integrate in the community services without, I guess, making tremendous changes in staffing patterns, but figure out a way to fit them in new and innovative types of ways that were initially, I guess, small changes in our programming, but have developed and evolved into larger changes in our programming. So some of the ways that we did that is we took a look at where we had gaps in services. One of our largest gaps in services was in our supportive housing programs. Odyssey House has several supportive housing programs and scattered site housing throughout the city, and often those clients have been dual diagnosed, and they often were not, we were not successful at engaging them in treatment. We would schedule appointments for them, they wouldn't show up, and things of that nature. So we said, how can we use in the community services to engage this population? So just a quick review of in the community services. We're not allowed just to go out into the community and do assessments everywhere. We have to have a reason to go and do those assessments. So what we did is we asked the case managers in the various programs to begin screening their clients for substance use disorder. Once they screened that they had a substance use disorder, we set up days where we would go into the shelter. I'd send a case act over to the supportive housing programs, and we would begin doing assessments. It was really quite amazing because what we discovered was that the engagement of the client previously, who wouldn't even make an appointment for an assessment, now had engaged pretty fully with the counselor that was sent to the supportive housing program. And I would say from that population, we increased engagement somewhere between 70 and 80%. I'm going to ask Victoria to talk a little bit about where they made their first changes.
Well, similar to you, Mary, one of the main reasons Silver Lake instituted in community services is because we noticed a gap in care. A lot of the case management organizations that we worked with were not either engaging new patients into treatment, or they were not re-engaging patients that were maybe non-compliant with treatment services. So we really wanted to bring the treatment to new and existing patients where they were most comfortable. In doing so, it limits the stigma associated with addiction treatment, and it allows for the patients to feel comfortable in known environments and engage with a clinical staff person regularly. Some of the current ways we do this is by bringing treatment services to current patients that might have dropped off in their attendance to treatment. So the one possibility could be that they have a medical condition that has limited their mobility and they're currently in a nursing facility. Another way is if their mental health condition is exacerbated and they might be in a situation where it's difficult for them to make it to the clinic. And basically any and all barriers to getting themselves to treatment, we will send out clinical staff people to bring those services that we provide on site at the clinic to them. And another way we do this is by reaching potential patients. So we provide assessments and screenings out in the field once these patients are identified as having a substance use disorder, as you pointed out, by the referral agencies. And what's great is it assists the referral agencies because they don't have to bring the patient's motivation up to a level where they have to get themselves to another facility. They can ask their patients to come and meet with them, and then we'll come during a regularly scheduled appointment that they might have with that referral agency. So it's been very useful to not only the patients but also the referring agencies and the workers within those agencies. So.
Right. Sometimes we at Odyssey House in our outpatient program, we treat a lot of adolescents. Adolescents are traditionally difficult to counsel in one-on-one individual counseling sessions. So we have a lot of young counselors who work with them, and so the counselors will take them into the community and maybe shoot hoops with them or do something like that. But while they're doing that, they're having that parallel processing that is the content of the individual counseling session. So that is another way that we've done an increased retention of our adolescents in our programming. And then finally, another thing that changed with the regulations was something called continuing care. So we'll have clients that have completed our outpatient program, and if they agree to participate in what's called continuing care, we continue them. They're discharged from treatment, but they are maintained in continuing care, and then we will use a lot of in the community type services with them. And maybe that they see a peer once a month, or they may have an individual counseling session once a month, or a session with our doctor. So that's a way that we have continued, have utilized in the community services in a continuing care program. Victoria?
Similar to what you were pointing out, Mary, we did look at certain populations that might benefit from in-community services, and we really looked at our full census and identified patients that we noticed, maybe older adults that have mobility barriers, or patients who are higher risk for relapse, especially with working with those patients. If the staff identifies that their patient might be at higher risk for relapse, they might work with specified staff that are good at crisis intervention work that can go out to the community. And I'll talk a little bit about which staff we utilize for that in a moment. But we could make an in-house referral to that staff member and identify, this person is at higher risk for relapse, even though they might have been coming more recently. It's kind of a back and forth, and we notice that they're exhibiting some signs and symptoms of pre-relapse behavior. And that really comes down to the primary counselors and the patients working together, working collaboratively, looking at ways to verbally contract when a service like that might be necessary. So it's really a constant conversation with the patients, even at intake and the current patients, talking about, we have this service, we can utilize this service, and what are the ways that we can bring this service to you when you need it most, because it must be patient-centered. If you don't have the input from the patients, it's not really going to work for you.
Okay. So we're moving on to staffing.
So as I mentioned, we have specified staff for in-community services, all of which are clinical staff members, QHPs, who are trained in crisis intervention, who are trained in all types of modalities that we use on site. They can bring that to the community. The main person that we utilize for crisis intervention is our diversion specialist. So that diversion specialist works intensively with myself, the clinical director, and our clinical staff members, and identifies what the plan of care is for each patient, and really helps the clinicians flag what high-risk patients are currently on their rosters. And it's a constant conversation, and that's where a lot of supervision and a lot of oversight comes in on my part, comes in on the part of all the clinical staff members, and really working together and constantly meeting and talking about how this service can be utilized. So this person is deployed essentially once they get a referral from clinical staff members, and I approve that referral, and then we identify the outcomes. We utilize in community assessments that this diversion specialist can bring with them to identify what are the risk areas. And really we get a lot of data that way, and it can help bring back the patient to on-site services and identify how the primary counselor can better support them in their individual work.
So similarly, Odyssey House, I guess the primary staff person that we use to go into the community would be our certified recovery peer advocates, who every client at intake is offered the opportunity not only to work with clinical staff, but also to work with a certified recovery peer advocate. Once they agree to work with a certified recovery peer advocate, we then have a few tools that we use so that, and the person is made aware that these are the information garnered from these tools is going to be used to help the patient if they're preliminary to crisis or in crisis itself. So the tools are, first of all, permission to have a certified recovery peer advocate meet with them in the community and on site. And once they've agreed to that, we use something called a matching questionnaire, which takes the attributes of the certified recovery peer advocate and the attributes of the patient, and we do our best to match based on the various attributes. The other tool that we use is a tool that's called a locator. No, not the Oasis locator, but a locator where the patient or the client will actually detail where they're typically found in the community, so that if they are in crisis or moving towards crisis, we not only have like their home address or their phone number or their email to reach out to them, we also have their like local haunts like the basketball court, the bridge, things like that. And we've actually gone on and located patients in that situation.
Hi, I'm Avraham Schick, the Executive Director of Silver Lake Support.
Hi, Avraham. So we're here to talk a little bit about outcomes, what we think the gains have been made over the last like year and a half or so using in the community services. So at Odyssey House, what we've noticed that there has been improved retention and improved compliance rates with clients because obviously when they're missing in action, so to speak, we do expend a lot more effort to re-engage them, and it has worked. There are clients that I do really believe that previously we may have lost contact with that we now have been able to re-engage successfully. We've also enhanced our census by increasing our client pool, because now we're reaching clients, I mentioned earlier, in our supportive housing programs, in certain shelter systems. We are actually just beginning to work with a primary care practice that's in the building with our clinic that just opened up to talk to them about screening and referrals and things of that nature. And also just going out and talking to everybody in the community, where we're trying to get the buzz going about in the community services, has really increased widespread community awareness that substance use disorder is a medical illness, and that as community partners, we can all work together to more successfully treat and integrate treatment for these folks.
So what's very interesting about that when you talk about in community services is, so you track outcomes similar to what Silver Lake has, and we have a tracking tool, and we develop different tools to capture different information, whether it's about our patients' medical conditions, mental health conditions, obviously the chemical dependency, and all other social and life areas like you've described. But we're doing that across the board for all of our patients, across the entire the universe of our patient population. But then we deploy our in-community services for our active patient case, and we can cross-reference that with these tools and these outcomes that we've captured, this data that we've captured for all of our patients, and see, all right, for this particular patient, did we deploy this community service for us, a diversion specialist? And what was the outcome of that intervention, and did that improve the health or well-being, or however we define that, did that outcome improve? And we can actually graph that, and it's certainly too early to tell. Certainly in the Silver Lake case, where we've just deployed this diversion specialist, the specific aspect of our in-community service, just maybe 8 weeks ago. So it's too soon to tell as far as the data, but certainly establishing those tools and being able to capture that data is critical when evaluating any aspect of the program, of course, but certainly the in-community service part for our active patient population.
Yeah, it's so great that you say that, Avraham, because I do think that the in-the-community services have gone a long way to assisting program providers with increasing availability of treatment to our patients, and thereby reducing the chance of reincarceration or hospitalization, because it increases adherence with follow-up on their medical and on their psychiatric issues.
The truth is that in-community services should be, and I was saying this before, should be a life changer for, not just for providers in the way we provide services and the where we provide services, but it should be a life changer, and it's happening. I'm sure it's happening at Odyssey House. It's certainly happening at Silver Lake. It's changing the lives of our patients. We're having a direct impact, an immediate impact, in many cases, whether it's patient re-engagement, or as you talk about, spreading the word, and the idea of just keep breaking the stigma of this, and the ability to engage patients where they're most comfortable. I mean, it's a literal meet them where they're at kind of concept. Is just having a real impact on breaking that stigma as well.
It really has. Challenges and solutions. Okay, so Odyssey House. I think that the biggest challenge for anything that's new and in the community services is not unique in that way, but buy-in and staff education is very, very important, so that our staff are our front line, and they're the ones that are connecting with the clients every day at every level. So getting the staff to understand the importance of the services and to connect it to the importance of the work that they're doing with their clients was our first step.
You know, Silver Lake had very similar experiences. Challenges, yes, not obstacles really, just things that we had to get done in order to really make this a success. Certainly in terms of staff education, getting staff buy-in, for our experience, for us, was almost immediate, really. I mean, they loved the idea. They loved the idea of having any kind of support that's in the community that's helping their own patients, really our patients, but patients that they're assigned to as a caseload to help re-engage in the treatment process. So they're very engaged. They're very willing to go into the community themselves if they've got the time. And I bring that up specific to the resources that it takes to really have staff to be able to deploy into the community. We made an investment in this. We hired a full-time person to do this without grant funding. So we look for the reimbursement that will help fund this, but we made an investment. We're giving it a trial period. And the idea is really that it's not just about whether or not the service that we went out to the community to provide was a billable service. It's also about whether that patient comes back to treatment, so now we've not lost a patient, so we've not lost revenue. So we're really recapturing revenue. That's ideal, and that's the ideal outcome. So as an investment, that's the kind of return that you want. So that's kind of the philosophy that we use as far as an implementation. And again, as I say, the staff, getting the staff to buy in, we have a real collaborative and real team approach to services at Silver Lake. So having them on board and understanding that piece and having them make themselves available to tag along with this person whose assigned role is to go into the community, it was just a lot easier for them to kind of grasp and help make not just a positive experience, but an effective one. Some of the other challenges, I guess, that we had to go through or discuss, certainly educating the patients, our active patient population, letting them know that we're now offering this service. It's not a situation where we're just showing up at their door and knocking on the door and say, hey, we're here, we haven't seen you in a little while. The ideal situation is where they know we have this service and that they've been warned that somebody may come out to see them if we haven't heard from you in a little while, and it's for their own good and for their own ability to sustain their own recovery. And that's something that's effective as well, because it's something that they want. It's something that they volunteer, that they opt into, so to speak. Not literally, but certainly emotionally and mentally. So that's been, that's kind of an administrative detail that we have to work through. There's always a concern we show up at somebody's home. There's some privacy issues, confidentiality issues. We want to be cognizant of that aspect as well. Who else is going to be home if we're going to a patient's home and so forth. But again, issues that we've managed to work through. Certainly the reimbursement and making sure that to the extent that we can, that whatever services that we're going out to provide are going to be reimbursed. The fee-for-service Medicaid is somewhat of a challenge, but again, workable.
I also think that it's helped with linkage agreements and MOUs with providers in the community, because when we talk to them about these particular services that we provide, it definitely makes for a more attractive partnership. So I think that that's really important.
For us, that's an important piece. Not so much the document, but it helps it's a springboard for the conversation with those agencies, and it helps kind of structure it for them, because that's something that they're used to, whereas this service is not something that they necessarily recognize, and you had mentioned this before, a significant value to them per se. But when you talk about our shared patient and the overall goal of the patient's health, and educating those agencies about this, that's been a challenge. Getting those agencies just to pick up the phone and let us know that they've got the patients, because we're doing all the work, they just need to pick up the phone, and getting them to understand that piece of it is all they need to do. I'm not sure they believe it.
Yeah, I know, exactly, until they experience something good.
Right.
Yeah.
So we hope that today's video has inspired you to get started on utilizing in-community services in your programs. I want to take this moment to thank all of our presenters who did a fabulous job explaining what their experience is like. And I want to thank you for watching. See you again soon.